Okay, welcome everyone to our Hertility Talks webinar on our guide to egg freezing. Egg freezing is one of the topics that everyone seems to ask about. There's been over a 400% increase in the number of individuals who are freezing their eggs. And so it stands to reason that we should be better informed, have easier access to care, and better understand what it is that the steps are towards egg freezing. We are super privileged this evening to have Dr. Benjamin Jones, who is an obstetrician, gynecologist, and fertility specialist at Hertility. Dr. Ben, your reviews after people have a teleconsult with you make me want to book in just to have a chat. We get glowing reviews from anyone who ever has a teleconsult with you following their test. They always report that everything is super clear and easily explained, and that they feel better informed and they know what to do. So firstly, thank you for that. And secondly, just to give a bit of a background on you, Dr. Ben, you'll do a better job of this than I will, explaining what your background is. So I am going to let you do that. But one of the things that we found exceptionally just special about Dr. Ben is the fact that he has dedicated his career not only to better understanding obstetrics and gynecology and fertility, but also pioneering change in experimental techniques, in novel ways of understanding things ranging from uterine transplants to ovarian tissue. And that, I think, really, I guess it makes me happy as a research scientist to see that there are clinicians out there who really want to break the mold, that don't just want to continue practice. It's one of the kind of stagnant things about clinical practice very often is people just want to follow in their predecessors' footsteps and want to get to a consultant post. You have managed to get to your consultant post now, and you've done so while researching and while really kind of fully wanting to understand outside of the box. So welcome. I'd love if you gave a small introduction to yourself before we go through our guide to egg freezing.
Well, thank you. I don't think I can do a better introduction than that, actually. It's probably one of the best introductions I've had, so thank you very much. So yes, I've been introduced. I've worked in obs and gynae for more than 12 years. As Helen mentioned, I've dedicated lots of my academic time to fertility and fertility preservation and restoration. I completed a PhD in fertility preservation and restoration, and this focused on a number of things like uterus transplantation, as Helen mentioned, and I'm the principal investigator for the deceased donor uterus transplantation trial, which is just restarting after COVID here in the UK, and we'll be doing the first uterus transplants here. And it focused heavily on elective oocyte cryopreservation or elective egg freezing or social egg freezing, which of course is what we're talking today. And I've published lots of papers on this, looking into various different aspects of it, the outcomes, the impact upon women's quality of life and their perceptions, and why women undergo this process. So I suppose we should just, on that note, crack on with the talk.
Let's do it. Okay, great. I am the master of the slides here, so I guess it'll lend well to a good conversation as well. And we can both, I think we'll come at this from very different sides. So you're coming at it from the fertility specialist, from the clinical sense, and I have fortunately frozen many oocytes. So I guess the physical process of oocyte cryopreservation and what actually happens when you take these oocytes and cryopreserve them, I'll lend my expertise where welcome.
Perfect.
Okay, we'll start with a little bit of a background.
Yeah, so as Helen introduced, so we know that the number of women that are cryopreserving their eggs is increased 400%. And we know that there's a reason for this. So over the last kind of 4 or 5 decades, as gender equality's evolved and there's been greater opportunities for women professionally, academically, educationally, we know that the age of first-time motherhood begins to increase year on year, and this continues to happen. This isn't just a UK phenomenon, this is happening now globally. And we know also that in association with this, that the rates of involuntary childlessness, so this is the number of women who want children, but unfortunately can't have them, usually as a consequence to age-related reproductive decline, or the fertility declining as age progresses. We know that these rates are increasing, and in the last 40 years, the number of women with involuntary childlessness has doubled. So that explains why so many more women are now thinking about cryopreserving their eggs. And we know that when even when you're a fetus, so when you're in the uterus, then you've got sort of 6 to 7 million eggs. And by the time you're born, as it says here on this slide, you've got about 1 to 2 million eggs. And then by the time you start having periods, this declines further to about 400,000. And then with each period or each cycle, you generally lose about 1,000 eggs. Now, don't worry, not all of these eggs are able to end up fertilizing and achieving pregnancy, but you usually ovulate, of course, 1 or 2 mature eggs each month. And then by the time you hit your late 30s, so by the time you're about 37, you've got about 25,000 eggs left. And then when you hit menopause, you're down to your last 500. So this kind of exemplifies sort of how ovarian reserve declines as age progresses. The other thing that's not particularly, it's not mentioned on here, is that whilst the number progresses, the very important thing to consider is that the egg quality also decreases significantly as age advances. So what can we do about it to assess ovarian reserve? And if, for instance, we were all the same and we all had a certain number of eggs at a certain age, then it would be very easy. You wouldn't need to have a special test to try and assess how your ovarian reserve declines. But unfortunately, that's not the way life works. And we're all different shapes and sizes, and that's the same with eggs or ovaries and ovarian reserve. Fortunately, there is a very easy, simple method to assess one's ovarian reserve, and that's by assessing your anti-Müllerian hormone, or AMH. The AMH is produced by all the different follicles that are inside your ovaries, so it acts as a surrogate marker of your ovarian reserve. And as age advances, as you would expect, as your ovarian reserve declines, so do your AMH levels. But there's other clues and things that we can learn from assessing somebody's AMH. For instance, it could be very high, and it might be that someone has polycystic ovaries, and polycystic ovaries on their own are nothing to worry about. They're a normal variant. About 20% of women have polycystic ovaries. But sometimes if you've got polycystic ovaries, you've also got irregular cycles, and you've got other symptoms that are suggestive of androgen excess or excessive kind of male hormones, things like acne or excessive hair growth, then this could be an indicator that you've got something like polycystic ovarian syndrome. And then if you've got a very low AMH for your age, then this could be an indicator that you've got a low ovarian reserve. Or it might be that if it's very low and that you're getting symptoms that are suggestive of the menopause, that you could go through something like premature ovarian insufficiency, which is when you go through the menopause before the age of 40. And one of the good things about AMH is that it doesn't fluctuate very much throughout the cycle, and it's very accurate. It doesn't tend to change very much. So it's a good marker that's accurate, and we can assess it at any time. So as you would expect, as age advances, your AMH will decline, and it gets to about a peak in your mid-20s. And then it begins to decline thereafter. And by the time you hit your kind of mid-30s, then it begins to decline that bit quicker as your ovarian reserve declines. And then when you hit your 40s and 50s, then the AMH levels will eventually become undetectable. And that's because all the follicles have been depleted. And then normally about 5 or 6 years later, you would go through the menopause. So what is the importance of checking your ovarian reserve? There are obviously numerous reasons why you would want to. And I think that the first and foremost is the fact that knowledge is power. And you can really be empowered to make decisions about your future reproductive plans based upon all of the knowledge. And you don't, you know, I suppose years ago, it may be that women who was kind of, you know, someone that hadn't planned to have children yet, and they hit 40 and then had attempted to conceive, and then they struggled, and then they would have found out that they had a, you know, reduced ovarian reserve. And by the time you've hit 40, the egg quality won't be quite so good. So that outlook wouldn't be particularly positive. But by being proactive, by having your AMH being tested, can give you so much more information and knowledge to change your reproductive aspirations and plans and plan around it. And it may be that you change your plans based upon your results, or based upon what you know or what you've learned here already today. It may be that if you're in a position, you're in the perfect relationship, you're married, but you're thinking, I might just leave it a couple of years because, you know, I want that promotion, or I want to move to a bigger house, or whatever. But then you might get your hormones tested, and it might show that your ovarian reserve is a bit low. So it might be that you change those plans. But then, like I said before, we can learn other things from your blood markers and your hormones. You can diagnose certain things like PCOS or premature ovarian insufficiency. And once you diagnose these things, then you can really then make changes. Maybe there may be some treatment that you can have that can make you be the best that you can be. There's one thing I didn't mention. That's one of the things, is that actually, if I just get a snapshot of your AMH, if you're say 36 and your AMH is 20, that would be very good. But actually, it's important to know where you are on that decline. And if your AMH has already begun to decline, if your ovarian reserve has begun to reduce quickly, then it might be that the following year it's reduced to 12 or 10 or something like that. But it may be that it's static and it's 20 again, or 19 in 6 months' time. So it's important to just keep an eye on things to make sure that you don't get overconfident if you get a good result at one point. So that brings us on to egg freezing, which is of course the main focus of today. And what is egg freezing? I mean, essentially it's taking eggs and storing them to be used in the future. And this enables you to have a biologically related child. Now, there's various, in fact, one of the things, and this is probably something that Helen knows a bit more about than I do, but the reason that this ended up becoming something that's so achievable and possible is the development that's happened by clever scientists like Helen. That they used to use a slow freezing method of freezing, which unfortunately it created ice crystals, and you lost a lot of eggs during the thawing process. But with the development of vitrification, which is a fancier method, which basically causes rapid cooling, but it doesn't cause the formation of ice crystals and therefore doesn't damage eggs. And we know now that the outcomes of frozen eggs using this method are the same as with using fresh eggs. So there's no risk really to freezing your eggs. And there's different groups of women that use egg freezing. The focus of today is more on the elective use of egg freezing, and the vast majority of women that choose to do this are those that are approaching their mid to late 30s, who are single, or they're not in a relationship where they foresee with somebody who they want to have children with. But there's other groups of women. It might be that a woman's been diagnosed with breast cancer or other cancer, and they need to undergo chemotherapy. And chemotherapy can damage ovaries. It can completely wipe out the ovarian reserve. So these women would essentially freeze their eggs prior to undergoing chemotherapy so they could be used at a future date. Or it may be that that people are undergoing gender reassignment surgery and they want to preserve their reproductive potential for the future. And there's various things to consider with egg freezing. One of the things is the storage limits. At the moment, the HFEA legislation means that you can only freeze your eggs for 10 years if you're doing so electively because of, say, social reasons. That legislation will change. It's already in process that it will change, and I think that will be confirmed in the short-term future. Helen, I don't know if you've got an update on that, but
it's I think we've done it.
Yeah. And of course, there's a significant cost implication. It is an expensive process. The cost can be up to £8,000 or even £10,000 for an entire cycle. Now that includes everything though, much of the time, and it can go higher. But essentially the cost of the ovarian stimulation and the retrieval and the freezing is usually about £2,000 to £3,000, maybe £4,000. So the upfront costs are a bit less. Then the storage costs tend to be a couple of £100 a year. And then the more expensive aspect is, of course, then the IVF or the ICSI and the development of that embryo, potentially genetic testing, and then the embryo transfer. One of the most important things is, and probably the most important thing about egg freezing, is that the reproductive potential of that egg is preserved at the age at which it's frozen. So for instance, if you're a 35-year-old and you've decided to freeze your eggs, that's at an age where the egg quality and reserve should be very good. It will retain that reproductive potential, and therefore you've got the pregnancy rates, the live birth rates, the miscarriage rates of a 35-year-old, even if you used it when you were 45. One of the other things to consider is that whilst those reproductive outcomes are much improved, and they are preserved at the age at which those eggs are preserved, there can be problems associated during pregnancy which are not impacted from the age at which they are frozen. So for instance, we know that in women that are over the age of 40, that when you become pregnant, you've got higher risks of certain things happening in pregnancy related to your blood pressure or diabetes. There's a high risk of stillbirth. So all these things need considering so you don't leave pregnancy too late. But again, the possibility is still there. And then one of the most important things, and it probably is the take-home message of today, is that whilst egg freezing is fantastic, it certainly gives women the opportunity to extend their reproductive potential and reproductive years. It's not a fail-proof method, and it cannot guarantee you a risk of guarantee you a baby, no matter how young you are when you freeze your eggs or however many eggs that you freeze. So to look more a bit about the practicalities of the process of what happens when if you decide to choose to freeze your eggs. Initially, you'd see a fertility specialist. They'll talk to you about your background, any medical problems, some of your family history, any previous pregnancies, or any previous IVF, and they'll talk to you about everything and make a plan about how the pregnancy will go and how they're going to end up stimulating your ovaries. And what they do is they do a number of tests. So they'll do some blood tests, again, the AMH, which I explained in detail before, and other hormones. And they'll do an ultrasound scan, and the ultrasound scan will assess numerous things. They'll check that the uterus is looking good and that there's no structural abnormalities that may impact pregnancy in the future. They'll check your fallopian tubes, and they'll check your ovaries. And one of the things that they look in your ovaries is to make sure that they're normal, but they'll also check the antral follicle count. And this is another really good way of assessing the ovarian reserve, in a similar way to checking the AMH. And what they should do at that point is take all that information and give you an individualized counseling on how many eggs that you would need, how many cycles they foresee that would be, and then of course a quote to determine how much that may cost.
I just say at that point, so along this journey, one of the reasons I guess that we built Hertility was that this journey is quite a journey to come to a conclusion before you even come to the conclusion about egg freezing and where you stand. And before you've even gotten to the ovarian stimulation, it's quite expensive when it comes to appointments to figure it out, an appointment to have the bloods, physically going into the clinic. And I think the first half of this journey, if anyone is considering egg freezing, is the actual reason we built Hertility, to enable somebody to have that consultation and triage to understand what is wrong with them, what may be the red flags associated with their fertility or reproductive health that might impact their journey, that we would do all of the bloods that you could do it from home, a very comprehensive calculation through our health assessment and then tailored test. And then actually what you can do is what we want to do is look after people throughout this journey. So we won't do the egg freezing, but we'll put you on the path towards the clinic by referring you to one of our partner clinics, and making as much of that journey, taking off the price as much as we can of that journey. Before anyone goes to your fertility clinic, they shouldn't hear me say this, but come to us, because you'll get a lot more comprehensive a report. It's okay. He's not conflicted. But you will get a much more comprehensive triage and report from the bloods that we do prior to going to a clinic. And you can go with them to a clinic, or we can refer you to one of our partner clinics, just to slide that in there.
So once you've made the decision, you need to start preparing, and there's certain things that the IVF clinic will prepare. They'll be looking at your drugs, working out which drug's best for you, based upon your background and your results. But also there's things that you can do, and there's things that you can really do to make sure that you're in the best shape possible to freeze your eggs or undergo IVF. It's important to make sure that you've got a healthy diet. So, at least 5 portions of fruit and vegetables, eating lean protein, trying to cut down on bad fats, or preserved food. And if you don't eat meat, make sure that you're not anemic. We know that anemia can be associated with poorer outcomes with IVF and also during pregnancy. So make sure that you're eating lots of leafy green vegetables, or if not, take a supplement. With other supplements, you should make sure that with freezing that you should take a multivitamin, making sure it's got enough vitamin C, vitamin D, calcium and magnesium. If you're eventually aiming to become pregnant afterwards, if you're not freezing, then you should make sure that you take enough folic acid. You should take this 3 months preconceptually. This is important to reduce the risk of neural tube defects or problems with the development of the baby's spine and brain. You should make sure that you exercise, so being active, being fit, making sure that you maintain a healthy BMI, making sure that your body weight is normal. We know that outcomes during IVF are not as good if your BMI is over 30. So it's important in this time to try and get yourself in the best possible physical shape to make sure that you optimize the chances of success essentially for yourself. Obviously, stop drinking, don't smoke, and that's probably about it. So, if this is something that you're thinking about, if any of these things have provoked any thoughts that you might want to either get tested, check your AMH, or maybe just you want children, but you're not, ready at yet, then I think there's various things that you can take home from today. I think it's important to just be as healthy as possible with all that advice that I just mentioned. You should listen to your body, listen to your cycle. Your menstrual cycle can give you clues for your health. And if you've got any symptoms that you think are abnormal and you don't feel like the GP's listening to you, then of course do something about it. You can get your hormones tested very easily and talk to somebody here at Hertility very easily. So be proactive and just think about all your options. And, we've done a bit of a whistle-stop tour of egg freezing here today, but, it is there as an option. It can't guarantee a live birth, but it is something that, you can consider for the future.
I'll talk a little bit about our test, because I think that's probably an important signpost. Somebody has asked whether or not they could, whether or not when they go to the clinic will make them do the bloods again. But once when you can go with these bloods, they're the same blood tests, probably more blood tests. We probably test more analytes than they might do in a given clinic. They might just do AMH and FSH and E2. We are really proud of what we built with Fertility. What we did was we didn't want to replicate something that already exists, which is just a test. What we wanted to take into account was, while we talk about AMH as a predictive marker for somebody's ovarian reserve, the reality is that that on its own is not enough to determine what someone's fertility is. As you mentioned, when you go in and you have a scan, which we can also arrange, you could have blocked fallopian tubes. These could be blocked from previous infections. And so when we built the health assessment for Hertility, what we wanted to factor in was lifestyle factors, previous medical history, any of your symptoms or biometrics that could actually in combination lead to a risk for any one of 9 gynecological pathologies. So it's while it seems friendly and approachable, actually the back end of what we've built is quite complicated, and there's some serious science that has gone on there behind to look for aggregating data from international diagnostic criteria and guidelines that are published and known, but not necessarily reliable for every woman. And so to me, a data approach where we can interrogate the different combinations of symptoms and hormones and biometrics and lifestyle factors to give somebody a better prognosis for where they stand individually, rather than just, on a scale for the general population. We know that statistics can do people a disservice, actually, and that's, I think, I hate statistics, mostly because I think we like everything to fall within the middle, right? We want everything to be an average. We want everything to fall within the range. And there are always outliers. There are always people who are on the extreme end of one or the other. And so statistics don't really serve them. And when we talk about fertility and egg reserve and egg freezing, people rely so desperately on these statistics. They just, the question is, what are my chances? What are my chances? What are my chances? How many do I need? What are my chances of having a baby? And so that's, I think, important in us taking into account the kind of 360-degree view, not just this snapshot of one hormone, but actually a whole collection of hormones that we test to determine what are the different risks that you may have. Thank you for that whistle-stop tour. We purposely kept it short and sweet so that actually we could spend the majority of this webinar answering people's questions. We're going to grill you, they're going to grill me, but that's, I think, what makes it a little bit more beneficial to everyone, because people have their individual questions related to them, but also the generalized question about what all of this means. So I guess as a recap, there are the various steps that somebody would take before egg freezing. You'd get your hormones checked, hopefully with Hertility. You'd have an appointment and have a scan, again, hopefully with Hertility. We're launching our scanning. We're really aiming to be there for the whole cycle for everybody. And then the word cycle actually stands to mind. So when you approach a clinic, they talk about multiple cycles. And what this really means is a stimulation protocol for every woman, so that they would undergo a series of stimulation in order to make sure that these follicles within their eggs or within their ovaries can be matured. So maybe we can talk a little bit to that, and we can get to some of the questions. I will stop sharing for now so that they just have us full focus. And maybe we can talk a little bit about the stimulation protocols itself and what does that mean? Because I think oftentimes we glaze over the details of egg freezing and we think, okay, cool, I'm going to have an appointment, I'm going to freeze my eggs, it's going to be done in 2 weeks, and that will be that. But actually what many people don't talk about are the side effects, how it makes them feel, how it makes them bloat, how they physically have to inject themselves every day with hormones. Maybe you could talk about what that actually looks like for somebody. I go to the appointment, I'm with you, I'm freezing my eggs, what are we going to do? You have my hormone results, what's next?
So as you rightly say, so it's controlled ovarian stimulation. So the aim of this is to stimulate your ovaries to a degree whereby we produce a good number of eggs. The importance of that is, of course, the more eggs that you get, the better the outcome in the future. We know that evidence suggests that the more eggs you get, the pregnancy rates will eventually be better. However, there are risks associated with stimulating ovaries. And as Helen mentioned, there are side effects. So we know that that you will feel bloated, you will feel tired. Essentially, they're common kind of side effects, but what we want to avoid is something called ovarian hyperstimulation syndrome. And this is a problem where your ovaries are stimulated too much and you end up secreting fluid in 2 different places where you don't want them, and it increases certain risks throughout the stimulation process. Now, with egg freezing, it's actually lower the risk of this because the fact that you're freezing all, you're not going to become pregnant, because the eventual risks of that can increase when you become pregnant. But to tell you a bit more about how the stimulation works is basically you will end up getting injections of something called FSH, or follicle stimulating hormone. And this is something that, as the name suggests, stimulates the follicles. And we keep a close eye on both you during this process to make sure that you don't get those symptoms and you don't develop ovarian hyperstimulation. But also we check your ovaries when we do scans to check the number of follicles, and we check your estradiol levels, which we don't want to get too high. Once we know that you have an appropriate number of good-sized follicles, this is normally 3 or more good-sized follicles, then we'll give you an ovulation trigger. And this is a different type of injection which really promotes the maturation of the oocytes. And then we schedule the egg collection for about 36 hours later.
So what we're really trying to do is, in any one menstrual cycle, all of these follicles, you will have a number of follicles, but we only have a baseline level of enough hormone, or FSH, or follicle hormone, to stimulate these follicles. We only have enough baseline hormones, reproductive hormones, to really mature one egg. And that one egg at ovulation is going to be released, and it waits to be fertilized. During an during an egg freezing cycle, we're basically supplementing those hormones to say, instead of just maturing one, we're going to give you enough hormones to try and mature as many of those follicles as possible. And then we're triggering ovulation. We're giving you essentially, we're mimicking this ovulation so that we can actually put in a needle. It's a transvaginal probe that a needle goes through the vaginal wall, which actually sounds a lot more brutal than it probably is, because somebody will be sedated. It's probably, I shouldn't say it's a little prick, but there you go, it is. And then that will actually be aspirated. So that needle goes through, and under ultrasound guidance. So while you're watching, basically you're looking at all of these what look like fluid-filled sacs, and you're hoping that there's a mature egg in all of them. So from the embryology side of things, what's happening is the person is there, they're waiting, you're at the nice end of the table, and you will fill these individual vials with this fluid, follicular fluid, and that may have an egg in it. This will be passed through to the embryologist, who is, as we go, pouring them into a dish and looking down the microscope and really looking down the microscope, and he or she will count the number of eggs. And so this process, I think, from when we think about the physical process, it's actually over really quickly. That actual removal process is really quick. So the embryologist will then receive the multiple vials as they're passed through, as you go from one ovary to the other, and count them up. And then that's when the oocytes will be cryopreserved. Right, it's quite a tense moment actually, because the embryologist is shouting 3, 4, nothing, and so it can be quite. I've been there many times where it's been nothing, 1, and you're really hoping for this person that there's as many as is needed. At the end of the day, we ask about numbers. What's that magic number? And while published literature says the golden number is around 15, that we hope that with 15 you're kind of safe, that one may lead to a pregnancy or a live birth. The reality is 1 oocyte, if fertilized, can lead to a baby, right? You just need 1, and that is, I guess I say that to give people hope, but also I think that it can be really disheartening when somebody gets a fewer number of oocytes, and what they're reading is that they needed 15, and so they feel like they need to go through this process again. And then I guess a moment for the freezing of the oocyte itself. As you mentioned, it's a technology that has evolved over the last few years, quite fortunately, with the evolution of newer freezing techniques that enable us to remove that extra fluid within the oocyte. And then I guess the reason for removing the fluid is that you wouldn't get this intracellular crystal formation, and so you preserve the oocyte much better by putting them through cryoprotectants, which protect them for freezing. And then they're put into liquid nitrogen at minus 196 degrees, and they're physically stored on almost like little straws, and then they're put into liquid nitrogen and kept there. Ben, just last week the news changed that the 10-year limit has been lifted
That's
So
it. It's
all
already
this
done.
advocacy work by the Progress Educational Trust and the people there has paid off. The storage limit is now up to 55 years. So it's originally that storage limit was 10 years, meaning that if a 25-year-old froze their eggs, that at 35 they would have to discard them. Now that that doesn't exist, so 25-year-olds can freeze their eggs, which is really great news. Up to a point, right? You know, we don't want to be transferring them too late, but it's good to know that it's a little bit better. I'm going to get to a couple of questions because there's quite a number here, and I think it will lead to more discussion as well. And I want to be mindful of time. So one of the first question here is about getting a reliable AMH result while on the contraceptive pill, or is it better to come off the pill before testing? Now I'm going to take a go at this first because we did a literature search on what the effect of being on contraception was. I think it's really important for us to define the type of contraceptive pill that you're on, whether it's progesterone only or combined. Nonetheless, your AMH is actually suppressed while on the pill. So we do know that when you come off the contraceptive pill, your AMH will go up. So actually, while some people can get a bit of a fright when they check, you can still check and it gives you a good idea. It's not going to double or triple when you come off your form of contraception, but it is definitely one to bear in mind, correct?
Yep, absolutely.
Yeah, great.
And then the other benefits of getting your hormones tested off the contraceptive pill is that, of course, we can check your other hormones. So your LH, your FSH. Your FSH can also give us a marker of your ovarian reserve. So yeah, there are benefits to coming off the contraceptive pill.
Definitely. I think it's one thing we have many people ask us, can you just do an AMH test? Can you just do an AMH test? And it's because they're convinced that that's all they need. And we are committed to not ever just doing an AMH test, because it's not the only the thing that will tell you about your fertility. Your FSH, your LH, your estradiol, your thyroid, all of these hormones are a beautiful orchestra playing the endocrine system, and they need to be playing all together in tune, and just one bum note can mess up your whole endocrine orchestra. So it's really important that we get a full picture of that, albeit that we can test your thyroid and your AMH while on contraception. Another question is around the quality of eggs. Does the quality of eggs decline the longer they are frozen?
So no, not particularly. We know that we can use them for a long time, hence why one of the reasons why the storage limits has progressed is that we know that you can use eggs for longer than that, and there doesn't appear to be any evidence that the quality does decline. Of course, this hasn't been around forever, and it may well be that if you end up freezing them for 20 years or longer, that there may be it's unknown at the moment, but at the moment there's no evidence to suggest that the quality is impacted.
I guess we have to be honest and say we don't yet know, right? There haven't been, egg freezing hasn't been around long enough for us to have said a significant number of people have frozen their oocytes for 15 years and that they've been thawed, fertilized, and led to a healthy pregnancy. We actually just don't yet have that data to really know, especially when different centers have different success rates when it comes to IVF in general. So it stands to reason that they may have different success rates when it comes to freezing oocytes. Okay, great. So somebody has asked, what's the best age to freeze your eggs? Is it 25 years old, 30, 35?
So I always try and make everything as evidence-based as possible. And one of the best studies that I like, I use almost in every consultation, is a study by Randy Goldman et al. It was published in 2017, and it basically created it predicted a likelihood model of achieving a live birth, depending on your age or depending on how many eggs that you froze. So for instance, there's good data that if, for instance, using this model, if you were 34, 37 and 42 and you decided to freeze 20 eggs, so this is more than the magic number that Helen mentioned, and we used to always say 15 eggs, but actually 15 eggs, it depends depending on how old you were when you froze them. So if you were 34 and you had 20 eggs, the chances of having at least one live birth would be 90%. Now that's very good. Now, as I mentioned, it's not a guarantee, but 90% is very good. I take those odds. If you were 37, the chance is of having at least one live birth declines to 75%. But if you were 42, it goes down to 37.5%. And that really exemplifies.
And that's even with the same number of eggs for each one.
So this shows how the egg quality is of importance. But also when you think about it, if I was to try and get 20 eggs from a 42-year-old, it would end up requiring multiple cycles, and then obviously much more cumulative cost.
Yeah, I think not just financial cost, but also physiological cost. Putting your body under multiple rounds of stimulation is not easy on your endocrine system, on you emotionally. And I think it's important to really pay attention to the emotional distress that it can put people under. A high percentage of people who are undergoing fertility treatment, whether it's for egg freezing or IVF, do feel isolated, do feel depressed, do feel quite scared. And I think for us, part of the channels we wanted to open up was around communication, to make people feel safe, not alone, that actually many of us have gone through it and are supportive, understand the fear. There's so much that goes into it emotionally, because what you're dealing with is, I guess, hope that your body is going to do what it's meant to do. And the irony that so many of us have spent our lives suppressing our innate ability to conceive, on the off chance that we got pregnant, and when we do want to, we are then saying, let's get this thing going. I hope let's kickstart these ovaries. So it's a really difficult place to be in. And when we talk about, I guess, the lifestyle factors that lead to infertility, but also our choices for egg freezing, the majority of women are not saying, oh, I'm just waiting to travel the world, I'm waiting for that promotion, or I want to buy a house. I think actually many women report, a majority of women report, that they haven't found the person that they want to settle down with. And of course, in the case of anyone in a same-sex relationship, if you are, read our fertility query guide on making babies in a same-sex relationship. That is a decision that I find many of my same-sex relationship friends, or if they're not in a same-sex relationship, they just put it off. And I'm trying to tell them, I'm like, 100% of the time, you are going to need to do this in the absence of just getting sperm and a turkey baster. You're going to freeze your eggs, so just do it. And I think there's an emotional hurdle that some people put in front of themselves. To us, I want to just make it really easy. If you were to say, right, let's save. And I worked out the maths for this. I thought, okay, under lockdown, people don't go out as much. They don't need to buy their coffee. They're not on the tube. They could actually legitimately, with tube, coffee and lunch, save £20 a day, ballpark, depending on where in London you are. And so I thought, yes, it might be hard to put £20 away a day. You could actually do that within like 6 months, you could have the money to freeze your eggs. That's a hard number to save for, but it is actually doable. And to me, I think making a conscious decision that you are going to do it, you're going to stick to it, you're not going to put it off, is one thing. The other alternative route is to say, I'm going to track my ovarian reserve. I'm not just going to do a snapshot. I am going to monitor my rate of ovarian reserve decline. We have team members in Hertility who have tested, thought they were fine. 3 months later, they've tested and said, actually, my ovarian reserve has dropped so significantly that I'm just not going to put it off. We actually are really proud of having many Hertility hatchlings that have been born as a result of people realizing they just want to do something. And while that may seem like high pressure, there is no pressure like the one that faces you when you actually cannot conceive and are going down the IVF route. So I think there's, as much as we talk about egg freezing, there's an awful lot of time that needs to be dedicated to acknowledging our situations and putting our bodies first, and maybe saying, I'm not married, I'm gonna have a baby anyway. I have my hashtag brides before babies is babies before brides. Sorry, I believe everyone should have a baby before they get married. I think it's meiosis over marriage, just to put it scientifically. So anyway, we'll get back to the questions. I just wanted to take a moment for either deciding, going with it and saying it could be a 2-week process and it'll be done and I'll be happy and I will have preserved my fertility. In the very least, I'll know. Or I'm going to monitor and I'm going to test myself every few months. Either way, you put the power in your hand, right? In your hands. So did we answer when it was best to freeze your eggs?
So but we kind of have. So
kind of, yeah.
In terms of the age, then 34 is it's easy for me to say. Then 34 is a very good age to freeze, or earlier.
I would say earlier than 34. I mean, I wouldn't say 25. No, I would say 30 to 32.
Yeah. So yes, so I can't argue with that because the success rates would be better. So if you know that you're not going to have babies until you're 40, definitely, Helen's right.
Yeah, fine. Yeah,
if you're doing it because it's a dynamic process and this has to be individualized, then if you're 30, then you've got 4 years where you could just meet Mr. Right on the bus or getting your expensive lunch, Helen. And
I'm not getting that lunch anymore. Remember, I'm saving for egg freezing. And I'm walking home.
Then if in terms of the age, the optimum age to get the best success rates, yes, the earlier the better. But you need to think about, the likelihood of whether or not you are going to meet somebody or your situation is going to change. Yeah. And therefore, if you end up doing it at 30, you meet the man of your dreams at 32, you have your first baby at 34, your second at 36, you've got all these eggs frozen, and you actually didn't need them. So I know that it's difficult and it makes it more, the decision making more difficult. But also what is important is, as Helen mentioned, is that if you do your AMH and it's good and you're young and you're 30, then you know that if you leave it for a year and it's still good, and then 32 it's still good, then you could reasonably leave it for a little bit. So I think it's individualized. It's difficult for us to make the decisions for you, but in terms of best outcomes, the earlier the better. But there's so many other things that you need to consider.
I think the main point is, and it goes back to my point about statistics, we can generalize all we want, but we have 28-year-olds who have premature ovarian insufficiency, and had they not tested, they wouldn't have known that actually they're closer to menopause than they are to making babies. And so this is, to me, that's why I think my exasperation with speaking to people who were so devastated, like you bear their devastation when you hear someone's story and they're crying saying, I just wish I knew. Why didn't I know? The media has me thinking I can have babies till I'm 45. Every image we see of Naomi Campbell, of all of these, women in their 40s are brandishing their new babies. There's no mention of the fact that they were probably donor eggs, that they could have been carried by a surrogate, that they, have gone through multiple rounds of IVF, or that they froze their eggs years ago. We never see, and we call it airbrushing ovaries, because that, I think, has been the most damaging airbrushing there has been to our generation of women who have been told that, you can have babies well into your 40s. And the reality is, when 86% of your egg reserve is gone by 30, it's a bleak statistic. It really is. And there's been this seismic shift in our perceptions and our expectations, right? So even I would say 10 years ago, getting married at 30 was, that was a good age to get married. Now I honestly view 30-year-olds who get married and I'm like, they're a bit young. Maybe that's my own warped reality. But there are a lot of, people are getting married much later. People are settling down much later. We very often have people say, I'm just checking in. I'm just kind of curious. I'm not ready to have babies yet. And they're in their 40s. And I feel sad. I want to say, why have we been lied to for so long about our reproductive capability? And the only thing we've ever been taught is our reproductive, that we are so reproductively capable that we're dangerous, right? Don't go anywhere unless, don't even look at it, because you're gonna get pregnant, right? I feel sad. I feel like part of our reproductive revolution is, speaking to you when you're 20 and saying, right, you're going to college, you're going to plan your career, you're going to plan your finances, want to plan your family. Now is the time to do it, right? Okay, we'll get back to some questions. I like to give out to people, or rather, I give out about the system more often than not. I think the question here that somebody has said about how many eggs is the most likely to be successful number saved? Is it worth doing 2 rounds? Again, it goes back to the exact same question. It depends on you. 1 round, you can have plenty of follicles, plenty of eggs, right?
Yep.
Yeah.
The other thing to think about is how many babies that you want from these eggs.
Yes.
And again, I've got some good stats. Sorry to blind you with the stats.
Yes. Throw us the facts.
But it's that same paper, and I really like the paper. I think it's really good. So going back to that,
what we'll do is we'll digest it. We'll put it into plain English, and we will email it to everybody afterwards with a summary of what the findings of that were. Yeah,
good idea. So going back to that one statistic, so if you were a 34-year-old and you had 20 eggs, you've got a 90% chance of having at least 1 live birth. So if you were 37, you'd need 33 eggs. And if you were 42, you'd need 100 eggs. And that's just something that's so unachievable, as I mentioned, the number of cycles that you'd need for that. So if you then thought, the paper goes into more detail and it looks about if you want 2 babies. So if you were the same ages, so if you were 34, you stored 20 eggs, you wanted at least 2 children, then if you stored them at 34, you'd have a 66% chance of having at least 2 live births. At 37, it would go down to 39%. And then at 42, it goes down to 7%. So you can see that earlier and the more eggs that you store, the better your chances. But again, it all depends on what you want to, want and hope to achieve.
And I guess there are many for whom they never end up using those eggs. People genuinely find that hard to part with them, to know what to do after a certain amount of time. My plea to you as a scientist is to donate them to research. It's what I wanted to do with mine. I was like, I'm just going to donate my own eggs to research. Scientists need them for better understanding processes like egg freezing, for better understanding all of these things that we're talking about. We need to know more.
Absolutely.
Back to the questions. So somebody has said, I recently had a total hysterectomy and only have my ovaries left intact. Am I still able to go down the egg and embryo freezing process with, of course, then going down the surrogate route?
Yeah.
Dr. Ben, you are the person to talk to about uteruses.
Yeah, definitely. So you've got your ovaries. So that's the most important thing with regards to having biologically related offspring. So you could undergo ovarian stimulation, egg freezing, or embryo freezing, and you could easily use a surrogate. Of course, I mentioned at the start, you could have a uterus transplant, but again, this is a very experimental process that we're doing as a research study here in the UK. Probably almost 100 have happened now, but it's associated with significant risk, multiple major operations, the use of immunosuppression. A surrogate, if you can find one, is a very good alternative and option.
How many, if you say 100 uterine transplants have been done, whereby a deceased woman has donated her uterus, this has been transplanted, 100 have been done, highly experimental, still quite dangerous. How many babies have been born to this?
So probably about 30. So when I've published the last proper review on the first 45 cases. So we know that most of the ones that have happened since haven't been properly reported. But from the first 45 cases, I know that there's been at least 21 live births. So there's probably, I am elaborating, but from the first 45, there's been 21 live births. Some of them had multiple pregnancies. There is about a quarter of them end up having a hysterectomy before completion of their family because of complications. So as you rightly allude, there is significant risk involved.
Still, I'm in awe of the ability to do this. I think it's amazing. Great, continue your research on that. Okay, somebody's asked, if you've frozen your eggs late in life, can you go through IVF with those eggs to have a baby when you're perimenopausal or menopausal?
Yes, you could. The risks associated with pregnancy. Oh, wait a second. So it depends. It depends how old you are. We don't tend to do IVF in women that are over the age of 40 in the UK. It's not good practice. And that's because of the associated obstetric risks. So the risks of preeclampsia, gestational diabetes, people can get severely unwell. I've had a case recently who was 55 and she ended up going to Sri Lanka for IVF, and she ended up becoming incredibly unwell with the severest preeclampsia I've ever seen, and she ended up on ITU for multiple months. So I wouldn't recommend it when you're postmenopausal, but I think anything less than 50 is within the realms of acceptability. But you need to be very aware of the associated obstetric risks, which you just need proper comprehensive counselling to discuss with a fertility specialist and potentially an obstetrician prior to embarking upon that, because otherwise a surrogate would be an alternative.
Great, thank you. There's a number of questions here, and then I'm going to actually do I know we're close on the hour, but I think we'll take a little bit more time because the time has flown. It flew. Whatever. Yeah, just because I think it's really good to get to some of these questions for people. There's a lot of overlap in the questions, and I'm doing my best to field through them. But one of them ones is, how long after coming off contraception should you then freeze your eggs, or would your AMH return to normal?
I usually say give it 3 months. It's probably a little bit earlier, but I routinely say 3 months. Yeah,
I think 3 months is a good mark for allowing the exogenous hormones to come out of your system and your normal endocrine system to get back to functioning. I agree with that. The other question that people are asking, and this is one that comes up all the time: what is the difference between freezing eggs versus freezing embryos? So a fertilized egg versus an unfertilized egg, and what are the difference in chances?
Okay.
And then I'm going to go because I like this one too.
You want to take it, or shall I?
Yeah,
start?
I'll take it. Right. Okay. So often people come to me and they say, we've been advised to, or I read that we should freeze our embryos instead of eggs. First and foremost, the process is a little bit longer. Of course, you need it's very circumstantial depending on your situation. If you are single, if you're single, then to me it stands to reason that you would just freeze your oocytes and your eggs. If you're in a relationship that you believe you're going to have a child with this person and you're both future proofing, then I would do a combination of both. I would freeze both eggs and embryos. Reason for this is that circumstances often change. There have been many cases that were brought to the Supreme High Court whereby the one partner no longer wished to use the embryos, and that person could not use those embryos because it's 50-50. Okay, even in that circumstance, that was that woman's last chance at having a baby. So the rules are there, and you're better off risk proofing. The reason that it is quoted that embryo success rates are better than egg success rates actually is a little bit of a muddied water, because what the prior publications that came out on that were looking at eggs that had been frozen in eggs and embryos that had been frozen through a slow freezing method. So prior to this new over 10 years method of vitrification. And when we talk about the constitution of an egg versus an embryo, there's a lot more water in an egg. The egg is predominantly made up of water, which is different to the embryo, which has much less water. And so when they were frozen back in the old days, their slow freezing method, there was much more ice crystal formation through that method in an egg versus an embryo. And therefore, an embryo had a higher success rate. Now with vitrification, that's no longer the case. As I mentioned, the published rates on people who've frozen, waited some time, and then had their babies, it's just not enough evidence there. But we know from fresh embryo transfer and fresh egg transfers that actually transferring fresh eggs that have been fertilized and transferred are comparable to transferring fresh versus frozen are comparable. So I think that decision should purely be based on quality of eggs, but also your personal circumstances. If you are in the position, if you are single, freeze your eggs. If you're in a relationship with a person, freeze a mixture in case things go wrong.
Yeah, I'd agree with that. I think you need to consider that I think what's the divorce rate? I think it's something like 30 to 40%.
I mean, just going through the process itself, when you're jacked full of hormones and it's really stressful and things mightn't be going wrong, it's a reason in itself that pushes people apart, which is really sad, but actually quite true. Someone said that if you have a family history of early menopause from 36 years old, do you know if funding is available for egg freezing? And actually, if you have a family history of early menopause, we should all be asking our mums what age they had menopause, because it really is reflected and is passed on.
And interestingly, almost all of the consults that I do, I always ask, and nobody ever seems to know. It's one of those things that we don't.
We're going to do a campaign, which is ask your mother.
Yeah. So it depends. Basically, it's mostly CCG driven, so it depends where you live to determine whether or not you would get NHS funding. They do fund egg freezing for women that are undergoing medical. Almost all of them fund it for women that are undergoing medical treatment that will make them infertile. So, for instance, if you're having chemotherapy and things. In terms of having a family history of premature ovarian insufficiency, then I think most CCGs don't fund it, but again, you just need to check what the arrangements are in place.
We have had 3 questions on the Mirena coil, maybe 3 or 4, asking about how long you need to wait after taking out the Mirena coil before you get an AMH check.
Again, I'd probably say 3 months. What do you think? I mean,
I think so too.
It doesn't stop everyone ovulating, but I think I'd give it 3 months, making sure that you have a couple of regular cycles and then getting it checked.
Yeah. Does freezing eggs negatively affect the ability to conceive naturally because you have fewer eggs? So the very logical rationale is that if you're going to freeze your eggs and you're going to remove all of these eggs, are you going to actually A, go into menopause earlier, and B, reduce your fertility as a result of having taken all these eggs away?
No.
Full stop. I'm going to press you on that and say no, but we don't actually know.
We don't know, but there's no evidence to say that you do. And the thing is, I think, we don't know, but we don't know, but there's no evidence to suggest that it does. And the thing is, if it brings through your menopause a year early, then, which we don't know, but if it did, then the quality of eggs at that age would be so poor that it wouldn't really make an impact. The key is that the egg quality, by undergoing spontaneous or trying to actively conceive at a reasonable age, you should not have any problems if you've frozen your eggs. There's no evidence to suggest that you would have any issues whatsoever.
Okay. So then I'm trying to scan through the questions to answer as many as possible. And what we'll do is we'll do a round of all these questions and aim to come back to everyone where possible with answers to your questions, because we really want to be there for you, or at least signpost the blog articles that we have on our website or the pillar pages on certain aspects so that you can read up on it. But I think many of them are around quality and what are the lifestyle factors that we can do to change. So we know that with all of your other hormones, there are lifestyle factors, medications, whether it's exercise, your diet, can all actually affect. Stress can affect your reproductive hormones, which are fluctuating anyway. With AMH, it is one of the ones that just steadily goes down, and it can fluctuate, because as somebody said, it went up. It can actually fluctuate throughout the months. One static number it's not always going to go straight down. It can. I test myself every single month. I can do that. It's my own experiment. Everyone on the team does, because we're trying to come up with a rate of ovarian reserve decline depending on no matter what age you are. It's a cool study. Let us know if you want to be involved. And that fluctuation, it shouldn't necessarily happen too much, but there's not much we can do to increase our AMH short of coming off contraception. But the question isn't around lifestyle and diet. What are the things that we can do to improve our, I guess, egg quality?
Just basically just be as healthy as possible. We know certain things do impact your ovarian reserve. Smoking's the big one. Smoking does impact your ovarian reserve.
Yeah.
Um,
Affects your estrogen, suppresses your estrogen.
And just maintaining a healthy BMI, so just making sure you're not too overweight, and then having a healthy diet and exercising to maintain that.
I think the biggest one for me is drinking. Not me personally. I mean, drinking is something I constantly see people doing when they're about to freeze their eggs. There's this idea, both when it comes to freezing your eggs and when it comes to getting pregnant, people are like, oh, pregnant, gotta be good. Oh, I'm freezing my eggs, I've got to be good. But it's really in the months before that, you can actually do an awful lot for your body. When you think about all of the eggs in each ovary, right? They're locked and loaded, ready to go. FSH comes along and it starts to mature them, and then one of them is going to come along. But in that process, in those roughly 14 days up to ovulation, your body and those eggs are actually exposed to all of the things that we have in our body. And I always talk about our cavity, that everything lies within this small place. And it was the most enlightening experience I had, going to, seeing a cadaver, this body, and doing anatomy and looking at the ovaries and looking at the womb and looking at the bladder just resting, and thinking, when we talk about our exposures like drink, and everyone associates it with an organ, right? They go, oh, your liver is going to be affected by drinking. And sure, it processes through there, but your brain is also affected by drinking. Your speech is affected, your limbs are affected, you start to wobble. Why wouldn't your ovaries be affected? And we actually know this through published literature, that drinking at certain parts of your cycle affects your ability to conceive. And so you're less likely to be able to conceive if you've been drinking in this early, really important stage of follicular genesis, where those oocytes are getting ready to go and they're maturing. It should be no different for egg freezing. My body is a temple. My uterus is so wholesome, but a lot of people don't actually consider that drinking has such a negative effect on their reproductive health and their fertility. And I think many people we've noticed have fallen victim to casual daytime drinking, casual evening drinking, a glass of wine in the evening. It seems to be the scapegoat excuse for how one would unwind. I'm laughing that you're not holding one right now. It is late in the evening.
It makes a change.
Yeah. I think that's usually my reproductive rant, is that, if it's we can always make excuses for it, but when you're going through this, you have one chance. Don't think of freezing your eggs at that exact moment and that is something you put away. Think of those as actually being your future offspring, and how much you want to nurture and give that the best possible chance. And we put ourselves through an awful lot, but putting yourself through egg freezing, if you're going to do it, give yourself the best possible chance, but give those eggs the best possible chance too, by really nurturing your body, not exposing it to stress where possible, alcohol, too much bad food. I think it's very often the easy things, but when they're easy and when they're obvious, it's much more easy to dismiss them. There, we are so wholesome and evangelistic, but really we just want everyone to have a safe journey when they do this. Dr. Ben, I've now kept you way past the hour. It's 9:10 on a very hot summer evening. Thank you so much for your time. If anyone has any questions, we can do another session. We can collate all of the additional questions and do another session together. I enjoyed this, so I can't keep talking to you forever. But what we'll do is we'll collate a little bit of information on egg freezing for anybody. We aim to answer as many questions as possible in your report. When you get your test and your hormone results, it should be very clear. You can book a teleconsult with Dr. Ben itself or one of our other amazing clinical team, and they will be able to put you onto the next steps. We can also refer you to our partner clinics, so please let us know if that is something you would wish. We can organize a scan and a referral to that clinic. If there's any other parting comments, Dr. Ben?
No, I don't think so. Thank you very much.
Thanks very much.
The pleasure was all mine, as always.
And thank you everyone for joining this. It's really great to see so many of you interested and engaged, and thank you for supporting everything we do at Fertility. We are really dedicated to making change in women's health, and we can't do it without people and you guys. So thank you so much and have a lovely night. Bye.
See you.